Okay, so in the previous video, you heard me talk a little bit about what kinds of information patients might receive when they are told they have diabetes. And so diabetes management is going to include educating the patient about their condition. So let's take a look at what diabetes is and some information a patient might receive about this diagnosis. I'm going to back up a little bit and briefly mention the types of diabetes. So these are conditions that are called diabetes, but they do vary in the way that they affect a person's body and, of course, in the way that they are treated and managed. So let's start by looking at prediabetes. A person is told that they have prediabetes if their blood sugar level is higher than normal, but is not high enough to be type 2 diabetes. It's still very important that patients receive a lot of information and start doing something about it, because prediabetes is very likely to progress into type 2 diabetes, and because it can be avoided with lifestyle changes. Even when a person is told that they have prediabetes, it is still possible that long-term damage, like damage to the heart, blood vessels, and kidneys, has already taken place because of these higher than normal levels of sugar in the blood. In this chart, you can see what the diagnostic criteria for diabetes is. And here you see that they are referring to prediabetes as impaired glucose regulation. But that's just what it is. It's prediabetes. When we talk to patients, usually it is referred to as prediabetes. So there are different tests, which we will look at in a little bit. But here you can see that there are different ranges. And for example, if we are going by a FPG test, which is a glucose measurement that is taken when the person has fasted, a normal result would be a number lower than 100. Diabetes would be a number that is either 126 or greater than 126. So then you have that range in between, that's 100 through 125, and that it's still not high enough to be called diabetes type 2, but it is higher than normal. And so that is what is referred to as prediabetes, or impaired glucose regulation. But as I said, because long-term damage of diabetes, especially damage to the heart, blood vessels, and kidneys, may already be starting at prediabetes, these patients do also get a lot of information and a lot of guidance on how to change some of their behaviors in order to avoid moving on to type 2 diabetes and increasing damage. Okay, another type of diabetes is diabetes type 1. And diabetes type 1 is not as common as diabetes type 2. Type 1 accounts for only less than 10% of all the cases of diabetes. As I said, like with all types of diabetes, there is an issue with having too much sugar in the blood. And the reason for that in type 1 diabetes is because insulin is not being produced by the pancreas. Type 1 diabetes used to be referred to most commonly as childhood diabetes because it normally develops in children and adolescents. Until recently, it was the most common form diagnosed before age 30, but that has changed, and we'll see in a little bit why. Now, I have a note down here about DKA, which stands for diabetic ketoacidosis. DKA is discussed with patients who have diabetes type 1, sometimes also with patients who have diabetes type 2, but it's not very common. And so in your case, what you'll need to know is that patients are told to watch out for the symptoms. So the types of things that you might be interpreting are the symptoms or the signs that someone might be in diabetic ketoacidosis state. And so that's going to include things like nausea, vomiting, abdominal pain. In class, we are going to concentrate mostly on type 2 diabetes. And the reason for that is because 90% of diabetes is going to be diabetes type 2. You heard me say that about 10% of patients who have diabetes have type 1 diabetes. Type 2 then is the most prevalent type. And so type 2 is characterized by resistance to insulin. And what that means is that cells don't respond normally to insulin. So insulin is not doing the job that it needs to do. It also is characterized by inadequate insulin secretion. So in addition to not using insulin appropriately, what could be going on is that the pancreas is not producing enough insulin. Type 2 diabetes used to be called adult onset, but because it has become increasingly common among children, because of childhood obesity becoming an epidemic, it is now simply referred to as type 2 diabetes. Type 2 diabetes many times is asymptomatic, which means patients don't show any symptoms until after a long while that they have had diabetes. And so in order to detect diabetes or prediabetes, screening is necessary during routine testing. And so unfortunately, many patients don't know that they have diabetes until they have developed a complication and diabetes has caused damage to their bodies already. Whether a person has symptoms or not, type 1 and type 2 symptoms are about the same. Increased thirst, frequent urination, extreme hunger, unexplained weight loss, presence of ketones in the urine, and ketones are a byproduct of the breakdown of muscle and fat that happens when there's not enough available insulin. So all of these terms that you see here, these signs and symptoms, are going to be terms that you will need to know how to interpret. You'll also need to know their definition. Even though you might understand what I'm saying to you in English as you listen to this presentation, you should know how to say these terms in your language of service. So I'm going to take a moment here so that you can practice how to say these terms: increased thirst, frequent urination, extreme hunger, and unexplained weight loss. Another sign of diabetes type 1 and 2 is the presence of ketones. And so ketones are a byproduct of the breakdown of muscle and fat. So in the beginning, you heard me say that we do need glucose, that we do need sugar, because that is the source of energy for our cells. But if the body is not using sugar appropriately, if the body is not using sugar or glucose for energy, because it can't, the body will try to look for another source of energy. The body will start breaking down muscle and fat to use it as energy. And when that happens, the byproduct, what results in that breakdown, are ketones that are then found in the urine. And so when this test is done and there are ketones in urine, then that's a way to know that the body is not using glucose appropriately. It is actually using muscle and fat to feed the cells. Okay, so now let's take a look at another topic that is discussed with patients who have been told they have diabetes. Nutrition is a big part of the discussion, as you heard me say before, because it very much affects blood sugar levels, right? So we do need glucose because that's what our cells use for energy. But what is important is a good balance of having enough glucose to feed our cells, but also making sure that we don't have too much glucose because that can cause damage. So when we eat, the foods that we eat that contain carbohydrates and sugars are broken down into glucose. And that's the glucose that our cells can use for energy. So after we eat anything with carbohydrates and sugars, and they are broken down into glucose, that glucose ends up in the blood. Our bodies then detect that there is an increase in glucose, and so our pancreas gets a signal to make some insulin in order to reduce or lower blood glucose levels. And the reason why it's told to make insulin is because insulin helps transport glucose into the cells. So insulin works like a key that glucose needs in order to open up the cell and go inside and then get used up for energy. When somebody has type 1 diabetes, their bodies make a hormone that destroys insulin. And so this is a response, an autoimmune response that gets triggered erroneously. So it should not be happening. And it attacks the insulin cells and it destroys them before they can open up the door for glucose to enter cells. When someone has type 2 diabetes, they either make insufficient insulin, which means that there is not enough insulin for the amount of glucose in the blood. And so what happens is that the cell doesn't get enough glucose inside of it to use. And the other thing that happens is that glucose remains in the blood, causing high blood sugar levels. Or in type 2 diabetes, the pancreas will sometimes stop making insulin at all, and there is no insulin, so no keys for the glucose to be able to open the doors of cells and be used up for energy. So now if we return to take a look at the signs and symptoms, after looking at what's happening at the cell level, perhaps we can understand a little bit about why those things happen. So for example, if we are looking at things like extreme hunger, okay, so because the cells are not receiving enough energy, your body will send a message saying, we need more food, because your body knows that the way that you can give it energy is by eating carbohydrates and sugars that then get broken down into glucose. And so it doesn't pay attention to the fact that there is a lot of sugar in the blood that's not being used. It just thinks that it needs more, and the way to get more is through eating. And so your body sends a message saying we need more food, which is hunger. And so a person with this going on is hungrier than usual. Now, unexplained weight loss happens because we are not using that food appropriately, but also because we are using fat cells for energy because we're not able to use glucose. And so we're burning fat. Fatigue happens because your cells don't get enough energy. Frequent urination happens because you are having to get rid of the ketones, which are the result of using muscle and fat for energy instead of glucose. And then, of course, the more you urinate, the more fluid you are losing from your body, and so that's going to make you thirstier. So then we see increased thirst. Okay, so again, a reminder that these are all things that you are going to need to know how to interpret, especially because these are signs and symptoms that somebody who is told they have diabetes will need to watch out for. Okay, so we did say that diabetes is a lot of times asymptomatic, which means there aren't any signs or symptoms that a person has diabetes until there is damage. And so what's important is to be able to screen for diabetes. As we learned way back in HCI 310, screening is a type of test that is used to check for a condition even when someone doesn't have symptoms. Now, something that you will notice is that the same tests that are used to diagnose diabetes are the tests that are used to screen for diabetes. Now, we'll take a look at how they are used differently. What I mean by that is how they are applied differently, but the names of the tests and the process uses a lot of the same tools. So when you're screening for diabetes, the first step is to assess risk factors. And the risk factors for prediabetes and type 2 diabetes, because that's what we're sort of concentrating a little bit more on in this presentation, are here in my screen. So one is weight. The more fatty tissue a person has, the more resistant cells can become to insulin. Now, I do want to make sure that we understand that researchers don't fully understand why some people develop prediabetes and type 2 diabetes and others don't. I want to make sure that you understand that there is a possibility that folks who are overweight will not develop diabetes, and that there are folks who are not overweight who will develop type 2 diabetes. These, again, are risk factors. So these are things that increase your chances to develop prediabetes or type 2 diabetes. The other thing that I want to mention is that risk factors is another one of those terms that you will need to know how to interpret for this class. So let's go back to the list. Weight, inactivity. The less active a person is, the greater the risk. So people who live a sedentary lifestyle, so folks who sit a lot, are going to be at greater risk. This includes folks who sit a lot for work, for example. A lot of jobs require that, for example, drivers and people who work desk jobs. And this is tied also to the weight, because the more active you are, the better you can control your weight, but also the more active you are, the more energy your cells need, which means the glucose that you ingest in your meals with your food is not going to remain in your blood. It's going to be used up for energy by your cells. Family history also increases the risk of developing prediabetes or type 2 diabetes. Race and ethnicity also sometimes can be indicators. Age, and as I mentioned, everything is sort of tied in, right? So the older the population gets, they tend to exercise less. We also naturally lose muscle mass as we get older and gain more weight. Again, we're not burning as much glucose, not using up as much glucose. But as you see here as well, and you heard me mention before, type 2 diabetes is also increasing among children and adolescents and younger adults because of how our culture is going, where there are a lot more activities that don't require as much physical activity, and also because of the types of foods we are eating. Gestational diabetes, and we'll talk about gestational diabetes in a little bit, but a person who has developed gestational diabetes in the past during pregnancy is at greater risk for developing type 2 diabetes as well. Other existing conditions like polycystic ovary syndrome which is also known as PCOS, also increases your risk of developing diabetes, as does high blood pressure and abnormal cholesterol and triglyceride levels. So the higher your cholesterol is, the higher your risk for developing diabetes, type 2 or prediabetes. So definitely folks who fall into these categories or who have these risk factors, they are going to be screened. Screening also takes place and is recommended for adults 30 and over. And it kind of depends. Some experts say 40 and over, 40 to 70. Some say 30 to 65. But it's around those ranges that it happens. And this is something that is typically done during a physical examination as part of your regular screenings, if you are within that age range or you have any of these risk factors. Okay, so let's take a look at one of those tests. We're going to take a look at the A1C test, which is commonly used to screen for diabetes, but is also commonly used to diagnose diabetes. The A1C test is also sometimes referred to as the HbA1c, hemoglobin A1C test as well. And this is a blood test that reflects the information about the average blood glucose level for the past 3 months. So it doesn't just tell you what your blood glucose is at the moment that you take it. It gives you more information by telling you on average the past 3 months what your blood glucose level has been. And so I'm going to leave this here because this is definitely something that is explained to patients, and it is most likely presented in this way. And as I mentioned before, A1C test is used both to screen for diabetes, but also to diagnose. But it is also used periodically even for those patients who have been diagnosed with diabetes and are being treated for it, in order to check on whether the regimen, whether the plan that was put in place for the patient is actually working to manage this person's blood glucose levels. And so what we're looking at here on the screen is how the results of A1C are received. And so we're going to take a look at what these numbers mean. So when we look at this chart and we see that a person, for example, has received a 6% score on the A1C level, that means that on average in the last 3 months, this person's blood sugar has been 126. That's on average for the last 3 months. Another way to screen for diabetes is to use a random blood sugar test. And by random, what is meant is that the patient doesn't prepare in any way. And if that result is a level of 200 milligrams per deciliter or more, then that suggests that a patient might have diabetes and needs to have further testing. It doesn't confirm it, but it definitely means that this person is at a higher risk for having diabetes, and so they need to do further testing to confirm it. Another test is a fasting blood sugar test, and in this case, it's very similar to the one before, but the patient is actually asked to fast overnight. If the result is between 100 and 125, the patient is then suspected to have prediabetes. And if it's 126 or higher, then the patient is suspected to have diabetes. Another test is the oral glucose tolerance test, which is referred to as GTT sometimes. For this test, the person is asked to fast overnight. Their blood sugar is measured before they eat or drink anything while they're fasting. Then at the doctor's office, they are given a sugary liquid to drink, and their blood sugar levels are measured throughout a period of 2 hours to see how the body is handling that sugar that it has taken in. If diabetes is suspected based on screening and risk factors, urine tests to look for the presence of ketones can also be done to confirm diabetes. Antibody testing and then the A1C test can also be used to confirm a diagnosis. In order to be able to use the results of an A1C test to confirm a diagnosis, the A1C test needs to be done twice. So you need 2 results that are administered at different days, different times, or 1 result of an A1C test and another test that is a blood test for diabetes. So another test could be, for example, the random blood sugar test, the fasting blood sugar test, or the oral glucose tolerance test. Okay, let's move on to talk about gestational diabetes. Gestational diabetes means diabetes that started with pregnancy. This means that a person previously did not have diabetes. Once they became pregnant, they developed diabetes. Gestational means during pregnancy. Gestational diabetes occurs in at least 5% of all pregnancies, so it's not common, but it's not uncommon either. The rate is much higher in certain groups. For example, the rate of people with Mexican, Indian, Asian, Pacific Islander ancestry, as well as for Native Americans, is higher than for other groups. If someone becomes pregnant and they are at high risk factors include being obese at the start of the pregnancy. If you had gestational diabetes during a previous pregnancy, or if you have a mother or a father or sibling or child with diabetes, then your doctor is going to test for diabetes at the first prenatal visit. If the person is at average risk of gestational diabetes, then they will receive screening tests for gestational diabetes sometime during the second trimester, typically between the 24th and 28th week of pregnancy. The initial evaluation does happen immediately. A commonly used test to test for gestational diabetes is the glucose challenge test, which is that glucose tolerance test, where the person will drink a sweet syrupy liquid. If the person's test is higher than normal, then a follow-up glucose tolerance test will be scheduled. Most likely what will be scheduled is the fasting glucose test, where the person will be asked to fast overnight and come in to have their blood glucose levels measured. And so again, if at least 2 of the blood sugar readings are higher than the normal values, then the person is diagnosed with gestational diabetes. So a little bit more explanation about those risk factors. High risk for gestational diabetes includes obesity. And what that means is a BMI of 30 or higher at the beginning of the pregnancy. And the rest are pretty self-explanatory. Gestational diabetes is important to control. So gestational diabetes increases fetal and maternal morbidity and mortality. Babies are at higher risk for being born with respiratory distress, hypoglycemia, which means a blood sugar that is too low, hypocalcemia, and hyperbilirubinemia, which means too much bilirubin in the blood. If someone who is pregnant does have diabetes that is uncontrolled or poorly controlled, whether it be pre-existing or gestational diabetes, that increases the risk of major congenital malformations. And so these are malformations that are developed in the womb. It also increases the chance of miscarriage. Poor control of diabetes later in pregnancy increases the risk of fetal macrosomia, giving birth to a baby that is too big. Preeclampsia, which is another term that you need to be familiar with for this class, and means new or onset of worsening of existing hypertension with protein present in the urine. Another risk is abnormal positioning of the baby. Your risk for cesarean section delivery also increases, and cesarean delivery is a surgical delivery by incision into the uterus, and stillbirth, which is death of a fetus after 20 weeks of gestation, so after 20 weeks of pregnancy.